Okay, thanks very much. George Kovac here, sort of virtually. So, airway pearls, stuff I learned at the bedside along the way and in the lab. Just a point to begin with. I'm not on any form of social media. If I've got something to say, it'll be on name Airway. I'll post something in our YouTube channel. This is where I live in Halifax, Nova Scotia, and this is where I work at the QE2 Health Sciences Emergency Department and Trauma Center. More importantly, Nova Scotia is where I grew up and where I built this place over 40 years ago with hands-on chainsaw with some friends in the middle of our province, a place of refuge for mind, body, and soul. It's a work and play effort, and I've got a different definition of play as I've gotten older. And I've gotten older too. Our families have our families expanded. These are my two grandsons, Graham and Levy. As full disclosure, this will be the only slide that you see about brisket. Those who know me realize that I like to make analogies in life and airway management to cooking a good brisket. I do need to acknowledge the fact that I receive support from the Dalhousie Department of Emergency Medicine, for which I'm very grateful, and I've been involved with teaching and providing AIM, our airway program, for over 25 years, and also acknowledge the fact that we've had a close relationship with CAPE over this time. So this is about airway management pearls and lessons from life and along the way, and then lessons from afterlife. It's important for me to acknowledge the most important teachers that I've had over time. This is Rob Sandusky, who previously managed our clinical cadaver program. He's a close friend. And those people who have donated their bodies as part of the program have been my greatest teachers over time. And I always say that collectively they have saved more lives than I or any of us will in a lifetime. This is from a recent session that we had. And every cadaver, every human is different. And this particular one, it was unexpectedly a very, very difficult airway. And if you were to have this scenario in real life, it would cause some great anxiety, as they would have been very, very difficult to intubate and become a failed airway. So let's start off with a case that I'll roll through. 35-year-old polysubstance overdose, and they aspirated. These are the vitals: heart rate's 125, blood pressure 90, SATs 81%. At this present time, respiratory rate's 36 on an FiO2 of 100%, and they're pulling off their face mask and are agitated. So Pearl 1 is fix your shit before you go. Resuscitate before you intubate. Most of us have come back to this important fact: is it's rare that you have to jump in and tube a patient. You do have time, and it is critical that you resuscitate your patient. There's been a lot of focus on first pass success. I keep on saying I've got a half-written paper on first pass success. Who gives a shit, or who cares? Because it's not really about getting the tube in. It's not about that success. And in fact, in this particular case, if you were to push drugs on this patient with those vitals as you had, it would have been a nail in their coffin. And the message has always been the goal of airway management is oxygenation, ventilation, and maintaining physiologic homeostasis. And a quote from Rich Levitan is, patients don't die from acute plastic deficiency syndrome. They don't die because we couldn't place a tube. It's because we couldn't maintain their physiology. So resuscitation sequence intubation, I'm referring a lot to Rich Levitan, a close friend and mentor. But this is the more important term as opposed to the rapid part of rapid sequence intubation. So slow down and fix your shit. And airway checklist is a lot of, argument about whether they're effective or not. If you design something well, it will be. And it's about not forgetting the little shit, because that's what makes a big difference. So spend the 30 seconds that it would take to go in to look at something before you go in. Pearl 2. Preoxygenation. Has been a lot of talk and literature recently about preoxygenating patients prior to them being intubated. And the way we look at it essentially is look at it in terms of good lungs versus bad lungs. Now, with good lungs, in patients that come in with, say, a head injury or an overdose without having aspirated, really it's about flow. So as long as you provide oxygen at a flow rate that is greater than their peak inspiratory flow rates, then you're going to denitrogenate them, and you are going to fill their lungs with oxygen. That's going to give you safe apnea time, which I'll talk about in a minute. In patients that have bad lungs, they have shunt physiology, but they need not only flow, but they need pressure. And people say, well, why don't we just use flush rate as we talk about, or as I showed in that previous slide? In other words, just crank up nasal prongs to as high as they get. Well, if I do that in somebody who's just sitting there, they will become agitated and with flows that are greater than 10 liters. Sometimes I'll do it to a patient that's over sedated just to keep them stimulated to breathe. And with a BVM, what you want to do is have enough flow that your reservoir bag doesn't collapse during inspiration as they're breathing spontaneously. So flow and pressure, this is just an example, a cadaver with a lung window, and you see that recruitment that happens and then de-recruitment, but that recruitment happens really without bagging the patient. So just keeping a good seal and having those flows with nasal prongs and some PEEP in this scenario, that's the pressure part of this. So having some PEEP, nasal prongs, and a BVM with a good seal, you will recruit alveoli. And this is we call it super BVM, and many BVMs are now fitted with these to begin with. So you've got a PEEP valve on that's a visual reminder whether you use it or not. You've got a pressure manometer, and you have waveform capnography that attaches to your viral filter. And this is Lonely Planet CPAP. And it can give you BiPAP, although I don't think it's best used as a BiPAP device. But this is a very effective tool, and I think everybody should have access to these components and create their own super BVM. So bad lungs, this is about flow and pressure, and we can do that with non-invasive ventilation. There's a certain amount of pressure that comes with high flow oxygen, and then using a combination of nasal prongs under a BVM, you can provide CPAP and you can provide BiPAP. Now, many of you know of the recent trial called the Preoxy trial, combination of EDs and ICUs, and looking at, published in that small journal called New England Journal of Medicine, looking and comparing non-invasive ventilation to other strategies of preoxygenating sick patients. So the Preoxy trial, and what they found was really no surprise. Most of us have been doing that, is that with the best method to do this is with non-invasive ventilation. It's the proviso is that they weren't comparing it against super BVM where they were using waveform capnography to ensure seal. But the real reason why non-invasive ventilation, I think, proves to be beneficial is when somebody's got a respiratory rate of over 30. In order for you to provide BiPAP, you have to assist those respirations, and there's just no way that you can do that safely and adequately with a BVM. A non-invasive ventilator is triggered by inspiratory effort, and that's why it's extraordinarily effective to use in these sick patients. So Pearl 3, pre-ox monitors. So let's go back to our patient. Let's assume their vitals are this and their SATs are 86%. And your non-invasive ventilator is unavailable. Again, if you were to push drugs in this, badness is going to happen. That patient's going to critically desat in about 4 seconds. And that's going to affect your physiology and your ability to perform, and airway management takes longer in those situations. So the most critical portion of your gear here is having waveform capnography, which we think as an after intubation device, but really what it's doing is telling us real time from the beginning, gives you breath to breath information about your seal. So if we have somebody whose saturations are 86% and we sort of say, listen, that's just the best we can, we're just going to have to go off and push this, the drugs in and push this patient into that apneic state to facilitate intubation. These are actually patients that I will do an awake intubation on. I'm not going to get into this at this point, but the point is make it better. And if you have waveform capnography on this patient with saturations of 86%, and you realize, geez, you got a shitty tracing, and your waveform, you got an end tidal CO2 of 15, then you might try, well, listen, let's just sit that patient up, make some adjustments. And then when you do that, lo and behold, your saturations improve. Right? So your waveform normalizes in terms of shape, and that's what you're using to adjust your seal. It gives you that breath-to-breath information. It's the equivalent of having an open lung window that you can see that lung. right? So it gives you feedback in the seal, and now that patient has improved oxygenation, saturations, and you'll be able to proceed safely with an RSI. So 2 monitors for oxygenation. It's waveform CO2 and your sat monitor, and 2 monitors for ventilation. One is that so you don't overventilate in terms of pressure manometer, having a pressure manometer, and you keep your ventilations under 20 centimeters, and to avoid overventilation and hyperventilation, because what do we do in situations of hypoxemia? We overventilate our patients, hyperventilate them, we drive down their CO2, and that's not good for the brain or their heart. Just another, again, a visual gift from seeing our cadavers. This is just normal ventilation and collapse without PEEP, and then you put a PEEP valve on. This is a PEEP of 10 in that scenario. And within 3 or 4 breaths, now you've recruited all the alveoli you need, and all the ventilation that you're doing after that is really just lowering their CO2. So, Pearl 4, know when to go in. Well, knowing when to go in is knowing that you need to spend as long as it takes, 15, 20 minutes, a half hour, or whatever it does to resuscitate your patient. And then also when you push those drugs, don't go in too early. If you want to have a patient vomit and have have to decontaminate that patient, it's going in too early. So know when to go in, and recognize that safe apnea time, what safe apnea time is, and that's our goal, is so that when we go in and do laryngoscopy, that they're not going to desat. Now, right now, all of your saturations are 100%, I would hope, but that's got nothing to do with safe apnea time. Your stores are about 400 cc's of oxygen. So your saturations tell you nothing about your stores of oxygen. If you denitrogenate that patient, you go from 400 or 500 mils to 2,500 mils, and that will give you safe apnea time. So what we're trying to do is increase the volume of available oxygenation. And just to summarize how we do that, phase 1 is preoxygenate using a BVM or non-invasive ventilation if they require that additional pressure support, or BiPAP. Use waveform CO2 and your SATs to monitor that. Phase 2 is after you've given the drugs, just gentilate your patients. This is a term that some friends and colleagues, Ross Hoffmeyer and Max Sorbello, they coined this term, gentilation, right? So gentilate that patient during that induction period. And then don't take the mask off too early, and keep nasal oxygen on there, and limit the time in the mouth, because as soon as you take that mask off, you will de-recruit. You will lose all that recruitment that you've done with your PEEP and your non-invasive ventilation beforehand. And then safe apnea time is not only just about increasing volume of oxygen, it's also about decreasing the rate of oxygen consumption, so give them what they need, fluids, blood, pressors, etc. Pearl 5, know how to go in. Again, a tribute to Rich Levitan here in a minute, but this is our RSI protocol that we use during COVID, doing all your PPE, make sure that you're wearing appropriate PPE, do your checklist, etc. And then you can do optimized video laryngoscopy. And you can use MAC VL with or without a bougie, or hyperangulated video laryngoscopy. So these are all Macintosh standard geometry blades. So the 3 most common devices that are out there is the C-MAC, the GlideScope, and the McGrath MAC. And they all have Macintosh or standard geometry blades, and then they also have hyperangulated blades. Don't refer to the device, refer to the blade. And this was an editorial that Adam Law and I wrote a number of years ago. It's not about calling it the C-MAC or calling it the GlideScope or calling it McGrath MAC. It's about knowing what blade you're using. So you're going to use a MAC blade or a standard geometry blade, or you're going to use a hyperangulated video laryngoscope. Use that terminology. That's what's important, because that dictates how you're going to approach with laryngoscopy, and also dictates how you're going to approach with tracheal intubation. The way we talk about is EVLI, and this goes back to a post a long time ago on MCRIT. So epiglottoscopy, moleculoscopy, laryngoscopy, and intubation. Epiglottoscopy, again, a term of Rich Levitan. Don't dive and pray. Right? Go slow, identifying your friend, and your friend is the epiglottis. Once you see the epiglottis, then you know where the glottis should be relative to that. If you go in too deep with a big scope, you're going to do esophagoscopy. Moleculoscopy, and what I mean by that is that, and this is important, it's regardless of device, whether you're using MAC or a hyperangulated blade, you want to see the epiglottis at the top of your screen and nothing really above it. If you look to the left, what you're seeing is the median glossoepiglottic fold, and we described this a long time ago, and there's a lot of pressure, and if you look at this video closely, it actually shakes. So there's a lot of pressure, and it's not moving the epiglottis, because that blade should be touching that median glossoepiglottic fold. And with that, then it's just a 2-finger lift. This is the same cadaver, the same situation. This is a 2-finger lift. This is the difference between somebody on the left who's inexperienced and somebody on the right who's more experienced. It's a gain of millimeters, and it's really about light touch and understanding the important anatomy. In general, for Macintosh laryngoscopy, the better the view, the easier it is. Now, bad views, so this is a grade 3B view, which is when I showed you that initial shot at the beginning with one of the cadavers, clinical cadavers we used recently in one of our airway electives sessions. That was a 3B view, and so that's a deflected epiglottis deflected posterior, and the one on the right is a grade 4 view. I judge studies actually in part by how they report the number of grade 4 views. In my career, I've seen one grade 4 view. I think Adam Law, who's a full-time anesthesiologist, has seen 4 in his career. I think the most common cause of these views are iatrogenic, that the grade 4s are actually esophagoscopy, and the grade 3s is that you're a bit too far and you're deflecting that epiglottis posteriorly. So it's understanding that anatomy and doing good EVLI. So Macintosh laryngoscopy, on top of a sniffing or back up, head up position, doing an additional head lift might give value. And that is a very powerful move. And if you need that additional lift, then you put some towels in underneath. Then you reach around and do ELM, external laryngeal manipulation, aka pushing the larynx until you get a view, and then getting somebody else to take over that. This is bimanual laryngoscopy to improve your view. Now, intubation with Macintosh laryngoscopy should be straight to cuff and 30 to 40 degrees, which is actually the bend of a hockey stick. Our American friends and others use the term hockey stick referring to a field hockey stick, I guess, but a 90-degree bend. So really all we want actually a straight tube. When we do, love to be able to not go around a corner and just place your tube directly into the trachea. So straight to cuff with a 30 to 40 degree bend. With hyperangulated video laryngoscopy, it's counterintuitive. You don't want to get this beautiful view. You want to look down the glottis and see a black hole. That means that your blade is aligned with the long axis of the trachea. As opposed to on the right, you're not only too close, but you're over-rotated and looking up at the anterior tracheal wall. And that's where you're going to end up with your tube. People feel passionate about whether they should bend their stylet. It's garbage that you're going to bend it as you see it on the left. It should be about a 60-70 degree bend. And what I do is I go to 90 and I back off a bit. Right? And we like malleable stylets because they're malleable, so when they go down the trachea, they'll also straighten out if you need that. If you're used to a rigid stylet, then fire ahead. The closer you are, and as you notice in the video on the right, we don't see the epiglottis, we're looking up at the anterior tracheal wall, and that first white bump in the trachea is actually the cricoid ring, and this is getting caught on that, and many people have been in that situation. It's when you are too close and you have to use a field hockey stick shape to get it there, as opposed to this deliberately restricted view where you're looking down the long axis and you see the epiglottis. It's easy to place. The other little pearl about intubation is that, if you rotate and drop your tracheal tube to the right, then as you see in the bottom picture to the right, the distal portion of the tracheal tube is in the same axis as the trachea as it descends into the chest, and the bevel is facing up, so it's less likely to get caught. And if you pull it back, the stylet 5 centimeters, and then the distal end of the tube is more flexible and allows it to go down. You're doing that all in sort of one motion, and then subsequently the tracheal tube or the stylet is pulled out. The other pearl, which is critically important, once you place the tube, don't back off and give high fives. Take an extra 10 seconds and look to see that you can confirm structures anterior and posterior to it. You see the epiglottis anteriorly, and you see retinoids posterior to your tracheal tube. A bougie, I'm not going to get into that. You make sure that your bougie has some degree of memory, so when you bend it, it will stay bent a bit. When to use a bougie, you can use it all the time. I'm not going to get into the literature for supporting bougie. I think it's strong and it's out there as long as you know how to use it. A bougie is useless in a grade 3B or a deflected epiglottis posteriorly, and obviously when you can't see structures. When you've got it out of the package, it's straight other than its coude tip. A pillow bend, I'll show you in a second. A deliberate bend is what you would use with a hyperangulated video laryngoscope, and there's some steerable tip bougies that are out there. A pillow bend is something that we do routinely, even when we're using Macintosh video laryngoscopy. It allows you to get around the corner, and sometimes your bougie will end up posterior, and if you rotate it in place without hitting teeth, etc., then it will get to the intended glottic inlet. Preemptive or versus reactive scenarios. So it's reactive, your lead edge of your tracheal tube's getting caught on right structures. So after that, what you do is you pull back, you rotate to the left, and it'll take it off the right-sided structures. Versus what we suggest is every time you put a tube on, preemptively rotate it. So Murphy's eye is anterior, and that will take it off right structures. So do difficult all the time. Pearl 6. When to stay and know when to leave. So confirming tube placement. We all think that this is in. That's great. Spend some time looking to confirming it is in. But there'll be situations where you go in and you say, geez, I'm not sure I'm in. And that's the great thing about video laryngoscopy is somebody can give you feedback and it becomes a team sport. But that in combination with no sustained waveform tells you that you need to pull out. This is a document that's been endorsed by every major Airway association around the world, and several groups, including CAPE, endorse this document. It's about prevention of unrecognized esophageal intubation, which is still happening. And there's all kinds of infographics. The point is, one of the major points I'm saying is you need to believe waveform capnography, and default move is to remove the tube. And this is not just something that happens to other people and junior people. It can happen to anybody, very experienced people who can't believe that this is happening to them. Because this seems easy, straightforward, that we should be able to put the tube right through this hole. This is the esophagus. When you realize that there's some anterior structure, which is the glottic inlet, that is the desired place of placement for the tracheal tube. And again, all kinds of images that will give you reassurance as you look at it, and then you get humbled by a more realistic view. So there's various recommendations that came out. The most important one is to use waveform capnography. And this should be distinct on your monitor because people will mistake it and look up and look at the SAT monitor, etc. So, this is an example of a shaded waveform. And that it's the only thing that gives you breath-to-breath information. Pulse ox is linked to the pulse. Waveform is linked to ventilation. And this is another important thing is you cannot use clinical grounds to exclude esophageal intubation. So auscultation, misting, all those things will lead you astray. So never use that to counter the fact that, well, we don't have good waveform, but you have these factors, right? So you got to believe it. If you don't have waveform, then pull out. And ultimately, that's what is suggested, is that the default move is to remove the tube and face mask ventilate or place a supraglottic device. Now, before you do that, of course, check to make sure that you're connected, you're not disconnected, and that the reason why you don't have a trace is something mechanical. And then the other important recommendation is to use video laryngoscopy because it's one of the other confirmation pieces. It's not the only thing that you're going to use. You're going to use waveform at all time, but video laryngoscopy is an important tool. All of these are esophageal intubations. Pearl 7, know if to try again. So is ventilation, if you failed your first attempt, you come out and usually what you're going to do is mass ventilate, and you're going to be looking for waveform capnography. And if you see sustained waveform, right, then you're good to go for another attempt. Recognize that your saturations are going to continue to fall because of pulse ox lag, and you're going to say to the room, that's okay, we expect that, we're okay because we've got a good waveform and sats will come up. So if this is the situation, then it's limited additional attempts, right? We don't want to do insanity, which is the Einstein quote, doing the same thing over and over again, expecting a different result. So you're going to do something different. If you didn't use a bougie, you're going to use a bougie. If you're going to switch to a hyperangulated blade, not because of the blade, but because you're skilled in using it, or somebody else comes that might have a better skill set for you. You're not going to automatically do 3, 4, 5, 6. It's that you're going to be doing something different. Pearl 8, know when to cut. So if you're in this scenario again, if at any point during your course of your first or your second attempt, that you cannot ventilate, you cannot oxygenate. This is when your psychological shock index is greater than 1, when your heart rate is greater than your patient's heart rate. You need to be committed to, and everybody in the room needs to know, is when you're in that situation that you've got abnormal waveform and your saturations are falling, that you're going to move to the front of the neck, or you're going to signal that person who's on the right side ready to perform a cricothyrotomy. Now make sure that you've done some problem solving first, and this is something that we're going to publish soon, but this is a index finger assisted mass ventilation to manage the leak. And that's a situation you might have taken out teeth. And now look what's happening is you got those index fingers that can come up and squish in those cheeks and fill that space. And when you do that, what's going to happen? Well, if you had a lung window, you'd see what you see here, but what you're going to see on your screen is good waveform. So know how to problem solve through difficult mass ventilation. In the same way, what happens, this is just me popping down a scope in a cadaver when you've got bad ventilation. And what's happening, the epiglottis is in the bowl. And what you do in this scenario, in the bowl of the eye gel, when you pull it back and do an aggressive jaw thrust, you can see the epiglottis appear, and then what you're doing is then reseating it, and then all of a sudden you can see what you see there. Right, so if you've got abnormal waveform and your saturations fall, that's a trigger to perform a cricothyrotomy. Know how to cut. So the scalpel finger bougie approach is the way to go. You stabilize the larynx, doing laryngeal handshake with your thumb and your index finger. Your index finger goes in to feel where you should go in. You make a stab incision. And this is just sort of showing the room that you'd have to put a bougie alongside of it. But instead of that, using our blade as a placeholder, we're going to use our finger as a blade as a placeholder. And you're going to see the blade come through the cricothyroid membrane space. And there's cartilage to the right, there's cartilage to the left. We're extending the incision, and then the blade comes out, and then the finger comes in, and you will never forget that sensation. You will feel cartilage all around your finger. You place the bougie posteriorly so you can feel it along your finger. You have to pull it out a little bit to be able to do that in this scenario, right? It's in, right? And then what are we going to do is you see the bougie going in posteriorly. Right, and then finally in this scenario, and this is me breaking up the film, you're gonna see the tube go through. You gotta tint it a little bit to get it through, or do a little bit of a push and twist, and that's the tube going in over the bougie. In the bloody airway, and there will be bleeding. It's even more important because if you try to sweep the blade over and then try to put a bougie alongside it, you're not going to be able to. Everybody's concerned here appropriately, but I've got my finger in and then a blade going in, and what we're doing in this situation is we're flexing that DIP and protecting our distal finger with that blade as we do the same technique. Know how to be the goodest. This is Pearl 10. Patient outcomes are about optimizing anatomy, physiology, contacts, but it's also about optimizing provider equipment and support. Our heart rate goes up and we lose fine motor control at a heart rate around 115. And remember us talking about the median glossoepiglottic fold. That fine motor movement of just 3 millimeters, you need to be able to have that. And again, with heart rates over 115, you might lose that. And these are bougie clicks. You're not going to feel bougie clicks when your heart rate is greater than that. We've actually shown that in a study that hopefully will be published soon. And you lose your ability from complex motor movements with heart rates over 145. So doing a cricothyrotomy is going to be quite a challenge. And certainly with heart rates over 180 or 170, people has a potential to lose bowel and bladder. So errors of omission versus commission. We are more comfortable in doing nothing and failing than having done something that may be perceived as the cause of failure. Think about that. And it is something that's a cultural piece. We avoid doing a cric because we think it's a failed airway and we don't feel familiar with that. The only way to make it real is to do simulation. We need to overlearn that procedure, practice it a lot, and do what we call System 1 training. Overlearning meaning you can't be just good enough at things that don't happen very often. You need to be better than good. And that's what overlearning does. It makes subsequent relearning attempts happen more quickly and decay happen over time. So learn is as many and execute one. These are the 11 steps required to perform a cricothyrotomy, and that's a practice attempt. This is just using our simple form of doing a front of neck airway. This is equipment and stuff that you can have available, and you can 3D print all of this and make the skins yourself. Stabilizing it, this beautiful model requires you stabilization, and again, we're going through those steps. With that, and that will give you an added experience as a System 1 training. So you learn as many and execute as one. And then if you have access to clinical cadavers, that's great. And you can also make things more complicated, and then you can elevate your heart rate. And we know that elevating your heart rate, certainly in a stressful scenario, can affect your performance. So do this after you've increased your heart rate. Lastly, I talked about the 4 C's in the past. Conscientiousness. This is all about so the 4 C's: competence, context, confidence, and conscientiousness. This is the lessons from that I tell my kids over time. Conscientiousness is the most important. It's about work ethic and working ethically. Work ethic means don't be upset by the results you didn't get with the work that you didn't do. We spend most of our other people that do complex scenarios, high performance athletes, fighter pilots, concert musicians, they spend 90% of the time practicing and very little time proportionally performing, whereas in medicine we spend very little time practicing and most of our time just performing. So we need to break that. We need to do what we should be doing. And working ethically just means at the end of the day, it's not about you and owning the airway, it's about the patient. And that's it. Thanks very much. Appreciate your time and you doing what you do. Take care.